Jeff Hansen, one of the co-chairs for the Center for eHealth Information Adoption and Exchange at the Patient-Centered Primary Care Collaborative, and welcome to our monthly webinar series. And this month we're pleased to co-sponsor today's webinar with the Center for Consumer Engagement, and I want to thank Warwick Charlton for joining us today. We hold these webinars on various topics on a monthly basis, and the next one is scheduled for Thursday, July 14th, so put it on your calendar from 1 o'clock to 2:30 Eastern Time. And next month we'll be featuring Pranav Kothari from the Renaissance Health, speaking on patient-centered medical home cyber infrastructure, current and future landscape. So I want to welcome you to today's seminar, and our topic today is health literacy and HIT implications for the new communication landscape. And I'll introduce our speakers in just a second here. But I wanted just to do some little housekeeping homework up front. We will save questions until the end of both speakers' presentations. However, during the presentations, you will see on the right-hand side of your screen a place where you can type in a question. Those will be gathered, and Warwick will be facilitating our Q&A at the end of the session. There will be a PowerPoint and video available of this session on the PCPCC website probably as of tomorrow afternoon. So please check that out, and you can refer other colleagues to there and also get some additional information from the PowerPoints from today's session. I do want to remind everybody on the phone to please mute your lines so that we don't get interference from keyboard typing if you're multitasking. And also, please be aware if you, I don't know how your muting works, but sometimes people put us on mute or on hold and music plays. So please be aware that whatever you do, we're not going to hear music as well for that. So without further ado, let me introduce today's speaker. First, we're pleased to have Dr. Christina Zarkadoulis, and she's a sociolinguist and internationally recognized expert in health literacy and public understanding of health and science. Her research focuses on analyzing and closing the gaps between expert knowledge and public understanding. Her critically acclaimed book, Advancing Health Literacy, A Framework for Understanding and Action, co-authored with Andrew Pleasant, PhD, and Dr. David S. Greer, Josie Bass Wiley, Publishers, 2006. It was reviewed by the New England Journal of Medicine, and they referred to it and called it required reading for public health professionals responsible for developing new tools for communicating with patients and the general public. She recently joined the City University of New York School of Public Health at Hunter to launch a health literacy initiative. Joining Dr. Zarkadoulis today will be Sylvia Chow. Sylvia Chow is Program Director in the Health Communication and Informatics Research Branch at the National Cancer Institute. She has interests in social media and health communication, patient-provider communication, and mixed methods health research. As a sociolinguist, she has expertise in a qualitative analyses of patient-provider interactions and illness narratives. She also conducts research on the role of technologies and social participatory media on health communication. In her role as program director, she is leading the effort to develop funding initiatives to examine the changing communication landscape brought on by social media. So without further ado, let me turn it over to Dr. Zarkadoulis for today's presentation.
Thanks very much, and we're very happy to be here. I think it's rare that anybody shows up when they see the billing as 2 sociolinguists, not just even 1. So we're very happy that you've tuned in, and we hope that what we're going to cover in the next hour or so can either match up to some of the things you've been thinking about or introduce some new ideas. I am going to assume that most people are not familiar with health literacy, so I'm going to dive into a few minutes of giving you a sense of where the field of health literacy has been and is now, and how we're now thinking about health IT particularly. And then I'll talk about one study I am particularly doing with my colleagues on how patients are actually using patient electronic medical records, and then turn it over to Sylvia, who will give you this 3,000 feet up picture of whole area, whole field of health IT, and then we'll stop for questions. So I'll start by saying, I guess, can I forward it on my own at this point? Let's see. It's not going forward.
Yes, you can if you click into the box. And if you also want to do the full questions, you can do that as well.
Okay. So I can't use my arrows?
Yes, you can.
Up and down
you can use your arrow. Yep, absolutely. Left and right arrow.
Oh, here we go. Okay. So when we think about health communications, we can think about at least a century's worth of sort of getting messages out and assuming and hoping that patients and the public respond. And I often say about all of this hard work we do in communications that as a nation we're overfed and undernourished. And here's some of why I make this contention. If you look at the sobering statistics of where we are as a country in terms of how much we read, it's very sobering. More than half of the adults in the United States are low health literate. Half of the population reads at 8th grade level and lower. And this is both from the National Assessment of Adult Literacy in '93 and then when it was repeated in 2003. So we're very clear that the situation is this at this level or even worse. What's health literacy? Well, I always use this example because I wrote it and I like it, but it generally is the wide range of skills and abilities that people use and keep developing over their lifetime to go search for, seek out, find, comprehend, evaluate, and use health information. Actually using it is the gold standard. It's one thing if you can understand well, the prescription label or the discussion of treatment options. Can you use that in an informed way to make decisions for yourself to reduce risk or to stay healthier? And when we actually scratch the surface of what is happening when you say that half of the adults in the country are low literate or low health literate, you wonder how we're making meaning together. I mean, these statistics that I just put up here, just to give you some example, our least literate adults happen to be our seniors. And if you look at most health communications that are written, even though seniors are reading at perhaps 5th grade level, most communications are written at 10th grade level to 12th grade level, and then if you get onto websites, you see an exponential increase in the load or the burden on reading 10th to 17th grade level. So I'm going to talk a little bit about readability, but leave that aside because that's only a small part of health literacy. We all got very interested in health literacy of the public at least a decade ago when we looked obviously at the projections of where chronic diseases were going to step up and be the key drivers of illness, health, poor health, and health care costs. And to deal with a chronic condition, you have to engage with the topic, with the illness, with your own disease management. And to do that, you have to have a degree of health literacy. So let me just make a distinction between two terms that you'll hear a lot, not just today, but if you wind up talking to somebody about this. Fundamental literacy, or literacy, is our ability to read, to write, to speak, and to work with numbers. That's literacy. And it's distinct from health literacy. But early in the field, the two got mixed up, and let me explain how. We started in the 80s, both with federal initiatives and then initiatives that came out of second language learning and education to call for making information easier to read, linguistically appropriate, and culturally appropriate and relevant. I'm sure some of you have heard those terms over and over again. And there was just a lot of vague understanding about what that really meant. Does that mean when you're putting out a brochure for mammography and you're appealing to a Latino population that you put pictures of Latino women? Is that culturally appropriate or relevant? And I don't know if we've gone very far in understanding the powerful aspects of cultural relevancy until very recently. So that was dealing with the literacy problem. And what happened is that researchers and practitioners said, well, okay, if literacy is the problem, let's just clean up the language of our health communications. And I'm sure a lot of you have either been taught in med school or teach in med school or nursing school, that you want to keep your language clear and simple. Well, I and my colleagues at Brown started doing research in this area about 15 years ago. And if you look at the first side of the page, a typical bit of language, say, from a health insurer, due to the fact that this drug is not on our formulary, we are denying your claim for reimbursement. And we'd put it in the simplification machine, and we'd come out with something like, we deny or will not pay your claim. We are denying your claim because this drug is not on our list of approved medications. Well, when we did actual comprehension testing, we found out that the cleaned up language wasn't any more comprehensible. And that didn't surprise us as linguists, because if you look and you do a health literacy load analysis of the message, there are things you need to know conceptually. There's an insurer, and this insurer has some authority to pay or not pay something. Okay, and there are medications that are on a list that seems to be changing all the time. You need to know something about generics and brand name drugs, and on and on and on. And so we began to reinforce and find evidence for the fact that just cleaning up language around health information was not going to bring us to where we wanted to be. But there were just a few of us doing that in the early 90s, and the vast majority of the field was still trying to figure out how to make these kinds of things, this prescription label, for instance, more accessible. And of course, I would say, yeah, that's a good goal. So on to the first, what I call wardrobe malfunction with this idea. Can you just clean up the language and really change people's health literacy and change their health behaviors? So let's look at an example of what Target did. Target, on its own initiative, took on the problem of high barrier prescription labels and brought together a group of health literacy experts and health educators and created a very readable label. Lots of white space, critical information in bold callouts. And last year, one of the largest studies so far of the efficacy of the label was published. And I just want to make this point. It was a large study, as you can see with the numbers, 23,000 plus target users, all with a chronic condition. I think it might have been statins, I don't recall right now. And then users in a matched demographic who were not using the target labels. And they expected that clearly the people who were using the target prescriptions were going to be far more compliant in refilling their meds and by proxy using them on time. And lo and behold, what they found was no statistically significant difference. And a bunch of us weren't surprised because of the fact that, again, we don't believe that the evidence supports just cleaning up the language to create more engagement, more understanding in health. Here's another example. I won't spend too much time on it, but it was a great ad aimed at consumers about 8 or 9 years ago to begin to work on the issue of don't keep asking for antibiotics, simultaneously encouraging providers not to be over-prescribing antibiotics. And when we did usability testing of these types of this particular poster and ad, there was no problem reading the headline, but people were annoyed because, I mean, if you read, and you can't sort of read the smaller print, it just advises you not to be asking for an antibiotic if you just have a cold, most colds are viral, blah, 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 blah. Again, we saw that people did not get the message. They were annoyed. When they're sick, they want something. And when you scratch the surface even further, looking at people's understanding of science, only half of the adults in this country understand the difference of virus and bacteria. So the first takeaway message is, yeah, clear language is necessary, it's great, but it's not going to be sufficient in most situations. And where that led us was a whole series of experiments. Some of you might have seen something like this coming around the web years ago. Take a moment to just read it. And I won't burden you with reading all of it. Most of you probably made sense of it. We do, as human beings, work with language and understand messages by placing them in a context. Oh, this is something about universities. I have some cognitive scripts for that. And I use the universal reading strategy, which is skipping and guessing. But we haven't learned that lesson in our communications with the public. So let's look at complexity for a minute, and then I'll present to you the model of health literacy that we developed about a decade ago. This is a still being viewed snippet of an explanation of H1N1 on the CDC website. I actually did a lot of study of consumers' understanding of H1N1 during the outbreak. If you just look at some key statements here. The virus was originally referred to as swine flu because laboratory testing showed that many of the genes in this new virus were very similar to influenza viruses that normally occur in pigs. And then it goes on to talk about further study with the new virus. When you do a health literacy load analysis of this, core science concepts, understanding something about a gene, or let's say you skip over not knowing what the gene stuff is, if you don't know something about a virus and why a new virus would be scary and how pigs fit into it, you can imagine the pseudoscience that floated around, literally floated around, about H1N1. I won't spend the time to go into a lot of funny interviews, not so funny. We did with people on the street, talking about how they understood the science of H1N1. So we talk about health literacy as being made up of a bunch of different kinds of skills, not just fundamental literacy, reading, writing, working with numbers, but what's our science literacy? What kind of science do we bring to the discussion of the treatment options or to the discussion of diabetes and nutrition? Civic literacy, who are we getting and trusting our information of? What do we understand about media? And cultural literacy, which I'm sure you're all somewhat familiar with. How do we use our personal and collective identification, identity frames to also take in health messaging? So I want to spend just a minute on the three categories: science, civic, and cultural. NSF has been studying public understanding of science in a large public understanding of science poll since the mid-70s. And it has been fairly consistent that less than 20% of the public is considered science literate. That means understand something about scientific concepts or the scientific process, scientific research, and most importantly for a lot of the work that I do, understand something about why science changes, that science findings and recommendations change. And I think the more I've been studying, and I've been studying this for 30 years, but the more I look into what people are conceiving of a lot of our medical recommendations or prevention recommendations, a lot of it goes into a real skepticism about science, because science is always wrong. Why can't they get it right, Chris? Why do they always like arguing with each other every time a recommendation is changed? So science literacy is a huge part of what we need to focus on. And very simply, I'll just read one example here. You know, most people do know that the Earth travels around the sun. Only 50, as I said before, 50% know the difference between an antibiotic and a virus. Or that antibiotics don't kill viruses, and one of my favorite ones is the last one. More than 50% believe the earliest humans did live at the same time as the dinosaurs. So again, science is sort of core to what we wind up talking about, even though we don't use the word science very much. Civic literacy is also proving to be a profound influencer. Who people trust? Do they trust their physician? How is that information trumped by community information, by information from the media? And now, as Sylvia will point out, how is that relative to all the information that's online? And I don't just mean on computer, but mobile as well. Here's an example of civic literacy, and if I had more time, I'd actually go through it. But it shows that most people get the message that the smoke, you know, somebody smoking on the back of the bus, somebody on the front of the bus could get that smoke and be at risk. What most people who don't have civic literacy of this kind don't get is that it's the smoker's responsibility not to smoke. So civic literacy plays a big factor in public health. I'm going to skip over these two examples of civic literacy and actually assume you know a lot about cultural literacy, the very importance of tapping into people's identity beliefs, community cultural beliefs, ethnic beliefs. And one of the programs that I highlight in the book, and they've really matured and evolved since then, is a tribe in the Dakotas with a serious diabetes problem where none of the conventional health communications material was working, hit upon using the traditional Indian food wheel and comparing it to the corrupted, supersized generation food wheel, and it became the most effective diabetes project that we've seen with the Native American Indians. So all is complicated enough when we deal with print, and along comes the technology revolution, you know, not just pushing information out on websites to people, which was Web 1.0, but Web 2.0, which is highly interactive, which is Twitter and Facebook and Google Maps. The numbers are staggering, and I'll leave most of the numbers to Sylvia, who tells a much better story. But the one, oh, I'm sorry about this slide's print. The one message here is that we used to argue that the digital divide was huge, and the difference between rich and poor, and access to information online, and access to just being online was enormous. We see, and if you're interested in this, go to the Pew Foundation's Internet and American Life website, and the voluminous and continuously growing and changing information they have supports the fact that online, on mobile resources are ubiquitous across populations, and there's also some statistics that show us, and I'll just spend a minute on this one, is 46% of non-Hispanic blacks and 51% of English-speaking Hispanics use their phones for internet access. And this is supporting a study that I'm going to be talking about now about electronic medical records, where we are finding that most inner city underserved populations that we're working with, Latino, African American, and other diverse populations, skipped over the computer era, and they have, what, as they say, as they show me their mobile device, this is my laptop, Chris. And we have to start thinking about that, because for you and I, we know our mobile is our tether in the world. And what we've learned is you can go onto Google now and move your house if it's in the wrong place. It's hot, you know, the whole, what we call crowdsourcing functions that came out in IT have implications for how we're going to be reaching patients now. If you heard the statistics that teens are sending 50 to 100 text messages a day, I think, or if you have kids, you'll buy into the fact that we're in a brand new world. So here in the last 5 minutes or so, I want to talk about the study that we are concluding in the next 6 months now with Sylvia's division at NCI, looking at the patient portal side of electronic medical records. We know provider electronic medical records are rather ubiquitous at this point. The patient portal side, whether you call it electronic health records, electronic medical records for patients, patient portals tethered to EMRs, that is rather completely unstudied among the underserved population. We don't know, are patients using them when they are available? Would they use them once everybody has access to them? And what are going to be the key barriers? We know we could expect that literacy is going to be a key challenge, and health literacy a key challenge. So we've had a study funded by NIH NCI to first look at, among our populations of low income, low educated, ethnic diverse populations, how they perceive of the ideas of electronic medical records for them, how readable and navigable or usable these actually are. And we focused on three of the main functions of EMRs. That is, you can manage your medications, you can renew medications online, you can review your medications, you can read about side effects. Importantly, you can see your lab test results. Your lab test results can be plotted over time. Is your A1C going up or down? How is your cholesterol doing relative to last year? And then key just-in-time health messages. How to prevent obesity in your children. Oh, you've been just diagnosed as pre-diabetic. What can you do, can you learn about, can you look into on your own time? So these are generally considered three of the most important functions of a patient portal. Problem is, there are over 300 different patient portals in the country right now. Some of them from big companies, big software manufacturing companies, and others very small, say built by a group of doctors or a hospital. So we spent 6 months looking at them from all kinds of perspectives. We did what's called a task analysis. If I were a user of this system, what would I need to do? How would I get online? How would I find things? Could I figure it out? We did a readability and a health literacy load analysis. How tough is the language, but then also what are the assumptions about what the consumer knows about health, science, civics, and culture. And we did focus groups first. And then we just completed the usability interviews. What we found initially was so exciting. We found, first of all, that, and these are our most underserved populations in New York City. We had a good representation of homeless men and women who were living in shelters, as well as people on the margins with families. And people were surprisingly technically savvy, and I dare say technically literate. If you look at these early statistics, they're holding up. Everybody had a cell phone, every single person. And the more we looked, more than half had smartphones, which are, essentially phones that connect to the internet. This is just one of the many public library facilities that we used to speak to people. Again, the most important things that came out of the focus groups is how wildly enthusiastic consumers were about being able to access their health information. They couldn't believe that they'd finally get to see their labs. They felt it was a civil right that they should be able to see this information. And they wanted it all on their mobile. Knowing that we didn't have to sell people on the electronic medical record was the first key finding. And very few people in our population were concerned about privacy. Very, very few. I don't know if this holds true for a larger population. I tend to think it doesn't. And again, these are just examples of taking small amounts of text. On the top of your screen here are the way in one electronic medical record, a patient portal, the patient's medications are viewed. What is the medication? About this medication is a link. Your instructions are right there, and then you can request a refill. with my colleague Sarah Zaja at the University of Miami, who is a cognitive psychologist, working on what cognitive tasks are there, and I working on the readability and the health literacy load, we began to predict a rather long list of things that were going to be difficult for consumers. Not flipping around saying consumers can't do this, but these systems are not made with patients and consumers in mind. I'm going to take you to the cholesterol screen now and skip over this. So we did 54 two-hour usability sessions with our population, and we would move through. We moved through 3 different systems, and we rotated them so there wasn't any bias in that. And we would ask people, if you were, and Mercedes was our fictitious patient, if you were Mercedes, how would you find the medications list? How would you find out if there are any side effects? So when screens are dynamic rather than the static screens here, usability becomes, a great fact-finding. The things we've found so far is that the search words that people are using, that they have in their mind, my labs or my problem, very often are not the words that the systems are designed for, that the systems use. And it's a huge problem. The systems are replete with medicalese, right? A lot of them are literally imported from the physician portal. Another example of just the overload, look at this page. This is somebody's blood count results, literally in their patient portal. Now, you don't have to be just low literate to have a problem with a table like this, I dare say. But the more we went digging, we've begun to identify a whole range of things that need to be and can be fixed in the electronic medical record. I'll just use this one as an example. With cholesterol, vast majority, 93% of our consumers could find the cholesterol number for Mercedes, let's say 240, but I think it's 53 or 59%, don't quote me, could not answer the question correctly, is Mercedes cholesterol normal or not normal? Or should Mercedes be concerned about her cholesterol? Because you have to first understand what standard range is, and second, do the number calculations to realize that 240 is over the 199. And I know it sounds very simple to us, but these are not simple tasks. So what do the EMR systems try to do? Provide people with graphs to make it even more difficult. We found many people were reading the graphs in the wrong direction and weren't getting much meaning out of it. So I'm just going to wrap up by saying, over the years, what I've learned, and I think I'm preaching to the choir here because you're all about patient-centered and consumer engagement. But the lessons I continually learn in my life with doing this work is you have to know who your audience is, not the one you want, the one you have, and you have to respect that. You have to know your material, and that doesn't mean know it as we as medical professionals or scientists know it. You have to know your material well enough to be able to do something like a load analysis, to scratch at the surface and say, what does this message really require? And I think we have to move more and more away from these older dissemination models. Let's just get the information out there. Let's push it out. Let's, sort of like the magic bullet of information we know doesn't work. We have to do far more collaboration because every bit of software that the public is using, whether it's Facebook or Twitter or eBay or Google, is highly interactive. And the younger the patient, the more they're insisting on this. And I think in conclusion, doing a health literacy load analysis to some degree is what we're training lots of physicians and nurses and health communicators to do, to get a handle on. Are there messages? are their materials appropriate for their audience, and how can they be improved? So I'm going to stop here and turn it over to Sylvia in the interest of time, and then at the end, Sylvia and I will both be happy to take questions.
Thank you. Am I on?
Yeah.
Okay, let me just make sure I can control okay, great. Thank you. Thank you for inviting me to speak at this webinar series. So in my work as a program director at the National Cancer Institute, one of my main responsibilities is to develop and nurture a growing area of research that's generally underrepresented in our funding or in our portfolio, and to gain funding support for new and emerging areas of research. So we know that in the last maybe less than 5 years, social media is really changing the health communication landscape. We're seeing a growth of new proposals and ideas coming in to look at interventions based on social networking sites, texting, looking at EMR, looking at mobile technologies as a way to enhance and maintain health. We also know that this whole traditional unidirectional understanding of communication, as Chris already pointed out, this conduit metaphor of from information to the recipient is really being transformed into a much more participative, interactive media. So the two ways we're trying to respond to these changes are to use some of our existing surveillance data, and that's a big part of what I'm hoping to show you today, using our Health Information National Trends Survey to look at and monitor and analyze changes brought on by internet and online activities. And at the same time, we are trying to stay abreast in the new and innovative research studies and interesting research questions to incorporate into our funding opportunity announcement, which I'll talk about at the very end of the talk. So what I'm going to do, I have kind of three major objectives. One is to use the data, nationally representative data, to look at internet-based technologies. First, overall usage, and then specifically health-related internet use, both in the general population and among cancer survivors, because that's a population we are particularly interested in supporting being at NCI, and talk a little bit about EMR, EHR use, and preference. And then secondly, it's a topic I'm very passionate about, and I think deserves a lot of attention, that is to look at the issues of digital divide in light of all these new changes in communication. And finally, I'll reflect on some of what I think these data are pointing us to with regard to patient-centered care goals and more effective health communication practice. So I start with a couple of major measures that have been used to gauge our the changes brought on by Web 2.0. So obviously, internet penetration is probably the first number people look at, and we know that up to, and perhaps is already being increased, 70% of U.S. adults reported having regular internet access, and about 66%, this is the data from the Pew Internet and American Life Project, shows us that about 66% of adults reported having broadband adoption, mobile technologies, obviously. And in terms of social media participation, our HINTS survey, HINTS data, I'm not going to spend too much time on the background, but if you're interested, that's something I can provide a lot more details on. But we see that about 23% of those who reported having internet use say that they participate or they have participated in the social networking site. And about 5% of Internet users reported having participated in an online support group. And about 7% reported having written in on a blog, both as a blogger and someone who potentially comments and writes in on a blog. And moving on to look at more health-specific Internet usage, we can see that there is a very large number of people who reported using Internet as their source of health information. In terms of health-related Internet use, we conducted a study that had just recently been published looking at cancer survivors' use of Internet for health purposes. And we find that about 16% reported having emailed their providers, 24% reported having purchased medicine or medication online, 8% support group participation, and over half of Internet accessing survivors reported Internet as the first source of health information. In terms of using social media for health information, we don't have a lot of data in-house to look at that, but several other data sources have already given us a sense of the proportion of population. So for example, this one research survey showed that 1 in 5 Americans use social media websites as a source of health care information. Here, it's a little bit different from just Internet, but it's more, Facebook, YouTube, and so on and so forth. So the way I define the differences would be the user-generated side, the interactive, participative side, and that would be a lot of people already going onto these sites and these activities for health information. In terms of the public's perceptions of PHR, personal health records, the HINTS survey has been analyzed by a number of people. One of them, Dr. Wen from Pennsylvania, has shown us that there is overall very widespread positive appraisal of electronic health records. About 86% of respondents, and this is generalized to the U.S. population, rated personalized health records as important. However, at least at the time the survey was fielded in 2008, the actual usage and participation was fairly uncommon. It's only about 9% of respondents. So we have seen, just over the last 5 years, a growth in the idea of needing more transparency in accessing data. So, for example, the demonstration project that many of you are familiar with, Open Notes from Boston and across the country, showed that there are a lot of enthusiasm and benefits. Of course, there are also concerns of privacy in particularly, psychiatric situations and other specialty care where this idea of sharing doctor's notes or charts with patients is generally being very encouraged by the consumer. But at the same time, people have definitely needs for more nuanced design and careful thinking on implementation. And many of you probably have heard of the ePatient Dave. I think he is a very good example of a kind of consumer-driven, patient-driven demands for greater transparency and access to health data. So now I'll transition to the second half of the presentation, which is really the issue of, given all that changes in technology and social media, and health information technology access, are we running the risk of leaving some people behind or marginalize certain groups? For example, we see that possibly 20 to 25% of U.S. Adults don't report having regular Internet access. So with a lot of the new innovations, are there persistent digital divide issues that we need to pay attention to? So every time I mention this issue, I get pretty much very polarized responses. One is really we are at the very timely or place in history to really bridge the gap because of the increase in access to technology across the population. And others would say, well, the population I work with would know all of this. So I think a great place is really to think about both sides, and that's why I'm really just trying to justify with, you know, the NIH leadership the need for more research and funding to really do more rigorous science to understand this issue of digital divide. So I'm seeing you can think about the glasses half empty or half full given the following data I'm going to show you. So we see that, household use is definitely predicted by income. So the wealthier populations reported having higher access to broadband. And that is the same with if we think about racial minorities or more at-risk racial and ethnic populations having lower access to broadband. So there are data also, a lot of people are interested in the in age. The age is a factor in terms of prediction for different types of social media participation. We see that if you look at each color, so whether it's the online support group on the green or the blogging on the blue or social networking sites, we see that every type of social media participation here decrease as in each successive, older age. So clearly, younger generations are more likely to participate in all these activities. In terms of health information seeking, I was going a little too fast. So this hint analysis asked people if you use internet to look for medical information for yourself. And we're seeing that for those who have less than high school education, there is generally less likelihood of doing that. In terms of race and ethnicity, we also see that non-Hispanic, Black, as an ethnic group tends to be least likely to be seeking information online. In terms of a PHR, or personalized health record utilization, I just want to quickly summarize a study by Dr. Dean Schillinger and groups at UCSF and Kaiser that's looking at the different ways people are accessing patient portal. This is specifically focused on diabetes population. So their main question is, do racial and ethnic minority groups and those with less educational attainment access internet-based services less often? Do disparities persist after controlling for access to the internet? And also, do groups vary in their level of access and function? So if you look at a PHR, there are various levels of involvement from just signing on, to requesting for a password, all the way to making appointments and emailing your doctors. So they want to look at differences in a whole spectrum of utilization. So they found that there is definitely overall less PHR use among minority patients. They also found that less educated individuals are less likely to engage in several of the PHR functions. So they also talked about how health literacy and the digital divide are really very connected. If you look at the darker colored bar, those with higher or more adequate health literacy by their measure have a higher likelihood of using these functions on PHR. So that's kind of the one side of it, showing kind of the fact that we still have this divide. At the same time, we also see that if we look at trend across time, the digital divide may be very well narrowing. So the general gist is controlling for internet access. We're finding social media penetrating the U.S. independent of all these traditional predictors of technology and health access, including education, race, ethnicity, and healthcare access. So in one of the earlier papers we published, I think it was in 2009, we found that this is a multivariate regression model that we actually didn't find any racial or ethnic differences across population in terms of social networking participation. If at all, African Americans may be slightly more likely to report using social networking sites. And you can tell we have really adjusted for age, gender, education, and a whole lot of usual suspects. We also found that minorities have equal or greater usage on most major social media platforms. This is data from the Pew Foundation. How about cancer survivors? So we conducted a study that's longitudinal in that we tracked 3 iterations of our HINTS survey to look at several health-related internet measures. And what we found, and you can see that the 4 of them that we were able to analyze, because those were the 4 variables that were consistently asked across the 3 iterations of the survey. We see that internet access is associated with younger age, being on Hispanic-wide higher education, and a metropolitan residency, and better self-reported health. But once we look at health-related internet use among those who have internet, again, we see no difference across race, ethnicity, and health status. And time since a cancer diagnosis did not affect health-related internet use in all of those categories. So some of the points to consider in conclusion. First, I like to kind of make some general points about for health promotion and health communication practice. Obviously, it is very important to enable equitable internet access. And I think that the rural population, especially without the broadband, without easy access to internet, won't be able to benefit from a lot of the technological advances in health IT technologies. We also think that the participative media has the potential for narrowing the digital divide. And thirdly, we know that so back in the public health world, there was a kind of a mantra about you got to reach people where they are, where they live, work, and play. And so we see that the data is showing us this increase in social media participation. However, that does not mean that the meaningful online health-related activities are also happening, or that health promotion efforts can necessarily be successful once you reach people who are on social networking sites. And in terms of communication interventions, it is very important to identify through, and I know Chris and I are both very enthusiastic about using mixed methods and qualitative exploratory methods to really understand the communication needs of a target population before you go on to do any interventions. And it's also very important to think about, and this is a big part of my job in developing this FOA, is to think about innovative and rigorous assessment methods to study social media impact. So clearly, simple, clicks and measures will not suffice, and really understand which functions are better fulfilled through the intervention planned. And lastly, to determine the functions of participative media. So like I said, just because people are on social media is not enough to say that health communication efforts would be successful. We need to think about what we're trying to do, what are the primary functions. Some examples, including peer support and connection and decision support, are places that I think have great potentials. In terms of how health IT connects to patient-centered care and the model of the primary care patient-centered medical homes, there are 2 points I'd like to just highlight. One is we know that patients are now armed with information they gathered from internet sources. So that's clearly going to influence the clinical interactions they have with their providers. So there's no assuming of a blank slate in terms of health information when providers meet with patients. So it is very useful to think about how to better enable a dialogue with patients to assess where they get their information, what they know about it, and to have a discussion of the credibility and level of trust of online health information. So secondly, in terms of thinking about a chronic care-oriented system, which is an important goal of your coalition, your group, how can health IT enable more proactive care and support patient involvement, patient education? So here at NCI, cancer screening uptake and willingness is a big goal in terms of addressing or alleviating burden from cancer. So thinking about ways to enable, whether it's a reminder education system that can be embedded in, whether it's the EMR, EHR, or other social media-based interventions would be an example. As well as enhancing patient-provider relationship building and coordinated care across different settings. And finally, just a few words on EMR and EHR development. So we know that there is a widespread appraisal of, and I'm sorry, it's EHR, across populations. So in addition to, making sure that we have an improved data management and monitoring system because of the electronic healthcare medical records, EHR also presents opportunities for developing more efficient and effective communication channels to facilitate patient-provider communication. And given that we see a differential utilization pattern, for example, in Dr. Schillinger's study of looking at patient characteristics and how they differ in terms of utilization, it is very important to give more thoughts to issues of the complexity of health literacy, as Chris alluded to, as well as the needs of the different specific populations. So just finally, we're actively continuing to build evidence base to support social media-based practice, as well as ways to enable more research projects to really look at these issues that I've discussed. And so the funding opportunity announcement is at the moment being developed, and I'd be happy to hear your feedback and answer any questions. And you can find our division and our websites in the link below. So thanks.
Hello, everybody. This is Dr. Warwick Charlton. Thanks very much to our two speakers, Christina and Sylvia. Those are very interesting presentations. This is going to be a short question and answer session, and if any of you have questions you'd like to ask the speakers, please go ahead and use the question box on the screen and submit them, and we'll try and put them to the speakers. So we have a couple of questions already. By the way, I noticed a number of people have asked about whether or not the slides are available, and I think it was said at the beginning of the webinar that they will be available on the PCPCC website perhaps as soon as tomorrow afternoon, both the audio and the PowerPoints, so that's where you can retrieve those. So Christine, one of the questions asked was if health communication is put at a 5th grade to an 8th grade level, do more sophisticated readers get turned off or disinterested in lower level health information, and how do you adjust for that?
I think the answer is Yes, they get put off because most of the ways that we tend to simplify information are done by making short, painfully tortured lists of sentences that nobody wants to read. They're actually really very taxing even for the low literate person. So it is when information is simplified and clear, and it allows you to continue to go on to read more if you're interested in it. I've never seen anybody complain about clear information. It is more that there's so much badly simplified information out there that I think it's really sort of confounded the issue of, gee, what happens if I start writing to a 5th and 6th grade level? I mean, obviously, the most highly educated folks, highly motivated, if they're highly motivated on a topic, don't want to read unnecessarily simplified information. But the general public talking about important health issues, absolutely.
Great, thank you. Sylvia, you mentioned that there was funding available for health information in cancer. Is that specific to cancer, or would it be for, or is that funding opportunity applied to all health communications?
So yeah, so definitely, so I shouldn't say there's funding available, if that would be a misunderstanding. We're developing this funding opportunity announcement. At the same time, people who are investigators who are interested in this area should not wait for the funding opportunity announcement to come in, as we have existing mechanisms that applicants can use to submit grants. And in terms of whether it's cancer specific, no, definitely not. I'm going to be working across NIH with other disease areas, and because I think in order to really address this issue, it's not a cancer specific issue, though if NCI is taking a lead, definitely cancer survivors, issues of cancer prevention will be of high priority.
Great. Another question for either speaker was, are there existing templates or resources that can be shared, that are available to be shared in the community that relate to healthcare and patient communication, especially with respect to the medical home?
I'm not familiar. I can't think of anything at the top of my head, but maybe Chris?
Are we talking about guidelines for communicating with health literacy principles in mind, or something specific to medical home?
Well, I think guidelines would be one component, and the second might be some resources that actually show, that are working / useful patient information guides around the medical home that meet the health literacy recommendations.
I'm trying to think. There are a few good websites. HRSA's got a public health literacy website. Health.gov has an improving health literacy resource bank there. NCI had a plain and simple guidelines book, and CDC as well has, if you go CDC health literacy, there are a number of downloadable, at each of these sites, a number of downloadable guides on what health literacy is and how you can use it in communication strategies. And then I wrote a whole book about this that is also available. So there are definitely resources out there, and I'd be happy to email maybe Christopher a resource list, and perhaps you could post it.
Great. I think that would be great. Maybe that can be posted with the PowerPoints.
Okay. I'm happy to do that.
Thank you.
Somebody asked about patient information being translated into other languages and how that's done, and the questioner asked particularly about Chinese, but I think it's applicable across all the varied languages.
I'll take that first, and maybe Sylvia wants to talk. One of the biggest problems, as you would expect with translation, especially for the average to low literate population, is that the translating services that, say, many hospitals are required to work with, whether they're in-house or under contract, have no expertise in special populations or literacy. So I have colleagues in health literacy who have a whole running library of the awful things that are done in trying to translate whether it's complicated information or specialized information for a low literate audience. So contraception becomes contraceptive bubbles and all kinds of endless insults to the consumer and the patient. What we ask for now, and what most people in minority health are really adamant about, is that you have to be looking for translation services that work on adaptations, not literal translations. And often when we're producing materials in multiple languages, I do a lot of work with the New York City Department of Health, we, the writers and the materials conception people, get together immediately with the other language writers before word one is written. So all the writers in all the languages know what the intent of the material is, who is the audience. Sometimes if we have the time and luxury, we come up with a group glossary. So just straight out translation services or interpretation services, and I know they're very different, yeah, if nothing else is available, yeah, go with it. If not, there's quite a way to refine that process, and it's important to do so.
Mm-hmm. Yeah, I'd like to add two things. One is, in light of the kind of crowdsourcing and Web 2.0, there may be some new innovative ways to improve translation through this type of, crowdsourcing. This is kind of a new area, but I know that, even automated translations have gotten a lot better. Even 2 years ago, it was just a joke, that, you can and do any kind of automated translation, but I think we've gotten a lot more sophisticated, and the same can be said about kind of user-generated or crowdsourcing as a method. And another thing I was thinking is, in terms of translation of materials, we are really here at NCI starting to pay attention to the importance of multi-level interventions. So if it's one thing is the print or the materials that needs to be culturally tailored and linguistically appropriate thing, but at the same time we think about the role of interpreter, and it could be professional interpreter, could be family caregiver, or patient navigators. They all have a large role to play in shaping the kind of interaction and the success of care. So those are probably all very related issues when it comes to linguistic barriers. So
that's great. Somebody said, is it a useful guidance to use conversational language as a way of writing healthcare communication as a sort of a default logic, if you want, when trying to address health literacy? And is that a technique that is useful or reliable?
You mean
Are you talking? Yeah.
So kind of conversational style to the writing style, I guess.
Oh, you maybe making written language not so confined to the written genre, but more spoken. Is that?
Yeah. Well, making the written healthcare information sound more conversational, and that makes it more understandable to more people. Is I guess the concept as a mechanism for addressing health literacy issues.
Well,
yeah.
I know Yeah, Sylvia, do you have something that you want to say?
That's an interesting idea. Yeah, I have to think about it. So if you have anything to say, please jump in.
Yeah, I mean, one of the things that we notice, that we know, first of all, print language and oral language are entirely different. Right. Their rules are governed very differently. We learn them differently. Our spoken language normally exceeds our ability to read from the time we're very young. But reading language that's more oral language is a skill. It's like learning to read a play script. Mm-hmm. And a lot of the push for, say, fotonovelas or things that rely heavily on dialogue, we've been studying, I haven't, but research has been studying that format for over a decade, and the jury's out. Mm. We shouldn't assume that making written language use the rules of spoken language is even possible. I mean, you and I are talking together, intonation, half sentences, what we do physically with our faces, the cadence, all are the cues to how we speak. They do not translate very easily to print, and so I would never suggest that as, I'd have to have resorted to and failed at a number of other attempts before I would select that.
Yeah, I agree with that. I agree with everything Chris has said. I do think it's interesting with social media interactions where there's a lot of kind of the bleeding, or how do you say it? So the spoken genre is bleeding into the texting, for example, and email. So from a linguistic standpoint, it's very interesting that that divide may be slightly changing with the way, we're texting our very oral spoken language to each other.
But it's in itself, if you look at the language of texting or tweeting, mm-hmm. it's its own language now. Mm-hmm. If you look at the codes people use, mm-hmm. It is its own grammar. And a matter of fact, some old folks like me, when we get our texts and tweets from our kids and nieces, it's hard to figure them out because we don't know the grammar of that language yet.
Those are great points. I think those are great points, and that's helpful. Another point, and I think it's a good one. People forget that the healthcare community is a community full of people with health care problems, and health literacy is one of those, maybe, but so are a number of other issues like blindness, low vision, hearing impairment, dementias, dexterity problems, cognitive issues like dyslexia, and they all impact the ability for people to understand and comprehend things. I think it's more of a statement than it is a question, but it's easy to forget that you're addressing a population of people with illness as well as low health literacy.
Mm-hmm. Yeah, good point.
There have been a number of questions as well about how consumers understand the quality of health information. So especially on the internet, what do you recommend for authors of health information to try and because a lot of social media type health information is not necessarily vetted or approved or even accurate, and how do you distinguish that? And one of the related questions is it important always to have references, or does having references itself raise the health literacy requirement?
That's such a very urgent and important question. I think I've seen that over the years. I mean, when social media first emerged, that was the key question: credibility and quality of information. And suddenly, we're seeing that because the floodgates opened. Information is ubiquitous and everywhere. That it's important to ask the quality question, but it's also important to think about how the different pieces of information either gets transmitted, misinterpreted, and it maybe started out being very, based on sound reasoning and science, but as the user-generated or this participative process continues, the information can be distorted. So I think it's definitely a key, important question. And I had another point, but if Chris want to go on, I can come back.
Yeah, I think the other thing that confounds how do you sort of trust and know what to trust is right now the populations that I study are more likely sometimes to be reading the blogs, which are more accessible, easier to read, more compelling, have some emotional voice to them. And you know, the blogs can be all over the lot. But I am again sort of saying, well, then we're going to restrict access. You know, we're going to have our patients only driven to this portal or to this site. I mean, the truth of the matter is judging the credibility and vetting information across others, friends, family, doctor, is what we do all the time.
Right.
And I think the more people, and I see it with our participants in our studies, the more they're involved with any form of media, social media or the internet, the more savvy they become. You know, even if they see something on sale, they know that that might not be a sale price. People have learned these skills in their daily lives, and they translate very nicely over time to new technology.
Yeah, I think, Chris, your whole discussion of science literacy really ties into this very well. This whole idea of ability to discern or, you know, think critically about a piece of information. I know that we have a whole theory about the wisdom of the crowd and the social sort of self-correcting that goes on these social networking or social media sites. But in a recent study we just finished looking at Facebook for breast cancer promotion, we found that self-correcting didn't really happen a lot. It's more kind of an open mic where people come and say what they want. Somebody said, well, you should throw away all your makeup because that's what's causing cancer, you know. And there's a lot of people who say, wait a minute, where did you get that? You know, well, how is that? It just kind of died, you know, and people come up with all kinds of, you know, I think very, you know, unscientific or, you know, but, you know, in that particular forum, there was not a lot of self-correcting, whereas I think, for example, in a voting or rating, kind of Yelp restaurant reviews, for example, that probably have more. You know, kind of crazy, outlandish ideas get thrown out, you know, more likely there.
Yeah.
Great, I think those are great points. Somebody noted that you referenced that Hispanics, I think this is Sylvia, you referenced Hispanics and African Americans using social media more than websites for accessing health information. And do you think that that's real, or is that a result of them using mobile phones as their main internet access and social media being much more accessible by phone than a classic website?
Yeah, I don't think I mentioned health information in that way, but definitely social networking site participation or social media use generally. So I think mobile could be, you know, one reason. Another is once they are enabled, you know, once internet is enabled, there's really nothing that predicts or stops people from, you know, doing the more interactive bits of using internet. So I think that's probably more the reason. So it's not necessarily minorities are more likely to, but the barriers just don't exist anymore. The entry barriers, you know, that we traditionally think of in terms of health literacy and information gathering.
Yeah. And then I think one of the final questions here is just an observation that the scientific basis for healthcare is complicated and getting more complicated to explain, especially, whereas alternate therapies are much simpler. and easier for people to understand. And this is a big disadvantage in trying to deliver high quality care. I don't know if you have any comments about that.
Sorry if I understood, what was the therapies?
Well, I think what the question is asking is that trying to understand conditions like rheumatoid arthritis that are autoimmune diseases, for example, that require special medications, where the patient just knows they've got a sore knee. It's easier just to go sometimes and get an alternate therapy that addresses your knee pain because it's a warm wrap, for example, and it's more logical and easier to understand. And that's one of the issues that more complicated care, that as science advances, so does this issue of health literacy become a greater problem.
Mm-hmm. Or a greater opportunity. I mean, if you look at, it's a question of how you see the problem. Say, you can tell somebody that you need PT, that you're really not going to get better, Chris, given your diabetes. You really need to be going to PT. The likelihood that your patient is going to do it and adhere to it over time is 50-50. And if we look at how many people do not, how many intelligent people do not take their medications as prescribed. And one of the things we've thought is, well, people don't need to understand why. They don't need the mechanisms. And I feel that that is a very old model and a very sort of almost disdainful model of the public. And I think it's our challenge to figure out how are we going to make the why of all this, A, accessible, engaging, and useful to people.
Great. One last question, and that is there a standardized way to test health information understanding? So if you publish something, is there a way to go back to your audience and test how well that was understood, that's standardized, versus testing, the health literacy load kind of mechanism?
There are very poor tests of health literacy out over the last 10 years, currently being recognized as, in essence, very poor reading tests. And in the wake of that, people have been developing newer tests of screening people's health literacy. But if you look at assessing what people understand, you have to look at in what modality are they receiving it. So is it a reading comprehension that you're looking for? Is it an oral memory comprehension that you're looking for? And I think you have to move outside of the field of health literacy to find instruments to assess the material. I think the big mistake we made over the last 15 years is applying readability formulas, the Flesch-Kincaid or the Fry, which were designed in the 50s, and the designers never intended them to be anything but a gross sense of the readability of something. We've been applying that to health material and coming up with grade levels to really no effect. They are very poor assessments because they can count words and syllables and length of sentence, but they don't get to what are the concepts, what are the ideas this information is carrying. So in essence, you could have a very readable paragraph about death. You are going to die, and these are the reasons why, and this is the disease you have, and it'll come out at a 4th grade level, and yet the profundity of the topic is not reflected in the reading level as we assess it.
Well, thank you very much, both speakers, for the excellent presentations and your thoughts and responses. Christina Zarkadoulis and Sylvia Chu, very much appreciated. As we've mentioned before, the PowerPoints and the audio will be available on the PCC website tomorrow. And thank you all attendees for signing in and joining the webinar today. We hope you can make the next one, and thanks all.
Thank you.
Thank you for having us.
The organization